A very good morning to all of you. So let's begin today's masterclass on diabetic retinopathy. How do we diagnose diabetic retinopathy? Now, when it comes to diabetic retinopathy, before we start into the clinical aspect, the most important thing is we understand what is happening. There is hyperglycemia due to diabetes, which is causing lot of metabolic dysregulation and stress. Now, what happens due to these things? Within the retina, there are two phenomena which happen. The first phenomena is that of the leakage, and second is that of ischemia. So let's first look at the leakage part. Now, normally there are pericytes, which are the cells in the capillary wall. They get affected due to hyperglycemia. This results in the weakness of the capillary wall and leakage, what we call macular edema. The second component is of the retinal ischemia and hypoxia. So, what happens is there is shutdown of the capillaries. Lot of chemicals are released because of the ischemia. These chemicals, of which VEGF is one of the prime culprit, they cause new vascularization. These new vessels are abnormal, so they bleed. They cause lot of fibrosis, pull on the retina, resulting in the fractional retinal detachment, which is the end stage of this whole game. So, how does it begin? As I mentioned, pericyte loss is one of the earliest signs. So, when that happens, you see microaneurysms like these small little dots. So, this is very early non proliferative diabetic retinopathy, and you do not need anything else to diagnose it other than your clinical examination. If you see it, just ensure good metabolic control and regular follow. As it goes on, the non proliferative disease becomes mild to moderate. So, you may have some hard exudates, as you can see in this photo, appearing under the fovea. On the fovea, some hemorrhages, dot and blot, and microaneurysms. Non proliferative per se does not cause any threat to the vision except if it develops macular edema. And what is macular edema? Macular edema, basically three things you look for to give you a clue. There could be a macular edema, retinal thickening in the macula, cystic spaces, and these succinate rings of hard exudates. Now we come back to our non-proliferative disease. As it progresses, you start seeing more and more changes of ischemia. The figure on the left, you see a arrowhead that indicates cotton wool spot. Cotton wool spot is actually a nerve fiber layer infarct, so which means ischemia is progressing. Whereas on the right, you see these venous beading and loops. Now, these loops, venous beading, they indicate the circulation is sluggish and there is going to be more of ischemia in the nearby retina. And this is what we call moderate to severe non-proliferative diabetic retinopathy. If you happen to do angiography, you may realize that the venous beading, near the venous beading, there would always be areas of capillary non-perfusion and there can be new vascularization as well. So what is advanced NPDR? You would see cotton wool spots, multiple retinal hemorrhages, venous beading loops, ARMAs, and capillary non-perfusion on FFA. It's very important to recognize advanced NPDR because this has a very high chance of developing into proliferative diabetic retinopathy. Now, how that happens, you see the figure on the top. This is the patient who had multiple cotton wool spots, hemorrhages, capillary non-perfusion, some venous bleeding in the periphery, and ARMAs. The patient was not kept under very regular follow up, and you can see 3 months later, the figure below, patient ends up with vitreous hemorrhage and requires surgery to treat that. 50% of the patients who have very severe NPDR will progress to PDR over the next 1 year. Now, you see here, this is the photo at presentation which has NPDR, severe NPDR, but within 1 year, you see all the large hemorrhages and all, because now it has developed onto proliferative diabetic retinopathy. So, if you're suspecting advanced NPDR, a very close judicious follow up is required, and you may even want to do angiography to look as there may be some new vessels somewhere. Coming to the next, which is proliferative diabetic retinopathy. What is proliferative? Proliferative means now the new vessels are proliferating. If you see carefully on this picture, the disc is showing NVD, which is the new vessels, abnormal new vessel. And if you go in the periphery along the upper temporal, there is a bunch of NVE. Now, these new vessels are fragile. They usually arise from retinal veins, and they often, they are abnormal, and they're actually a collection of fine naked vessels. So these fragile vessels tend to bleed, and they may cause vitreous hemorrhage or preretinal bleed. So this is what you can see, this patient of NVD which has bled. Here it is shown beautifully that you have NVD and the blood is trickling down and it is forming a boat-shaped hemorrhage as well as vitreous hemorrhage nasally. New vascularization elsewhere are NVE. Any new vessels which you see beyond 2 disc diameter of the optic disc, that is called NVE. Now in this figure you can see NVE superiorly. If you are in doubt and you're not sure whether there is NVE or not, please get your angiography done, because the angiogram will show these multiple areas of leakage much more clearly whenever you are in doubt. Now, the proliferative diabetic retinopathy progresses. You have abnormal vessels, they grow along the posterior hyaloid and they start contracting the posterior hyaloid. So when they start contracting, there is a component of vascular as well as fibrosis. So due to that, the underlying retina gets pulled along with it and it produces the so-called tractional retinal detachment. And many a times, the contracted vitreous also pulls on the optic nerve, optic disc and causes a traction which looks like this. It's typically called the tabletop traction. Towards the end, there is development of the detachment. As I mentioned, there is fibrosis, there is bleeding, and it might result in the tractional retinal detachment, as you can see on the left. And many a times that traction causes a pull on the underlying retina, results in the development of a hole, and one might develop combined retinal detachment, which is the end stage. So, to conclude, I think what every ophthalmologist should know is how to characterize diabetic retinopathy. Is it non proliferative? Is it proliferative? Is there a macular edema? Is there no macular edema? During these subsequent talks, we will realize that most of our management decisions are based on this initial characterization. So, this characterization remains the most important part of managing diabetic retinopathy, and it does not require any sophisticated gadgets to diagnose and characterize. As I showed you color photos, that is your clinical examination. So the clinical examination is enough to characterize diabetic retinopathy. Thank you very much. And our next talk will be now focusing on diabetic macular edema. Thank you.